So I do have an online question for Christy. Is the answer to upscale vaccination rates the way that First Nations people want? And what are the key drivers to change public health models aligned with First Nations people's needs?
It's a great question. I think we need to talk with communities in a broad sense and understand the contextual issues that impact on them. All the areas are going to be very different, but I guess the perspectives and experiences and challenges are going to be very similar. So I think, getting together our First Nations leaders in this space is a step to understand those. And, they're very connected to the communities in which they live and work and can bring forward those challenges. And they've probably already been told the solutions by community. So if we provide a space for First Nations leaders in this space to get together and put forward those challenges and those solutions, then hopefully that can be a way to influence policy and programs across all states and territories.
That's excellent. Thanks so much. I think we have a question in the room.
Angela Newbound, I'm an immunisation education consultant, also work at Adelaide Primary Health Network as the immunisation coordinator. I think, the conversations over the last 3 days that we've had and conversations today, I think there are many really great ideas, but I think the problem is, where do we take them? And I think it would be lovely to have, so perhaps a barriers and a solutions bucket that goes to a think tank. And I think something like the Immunisation Coalition would be great to lead that think tank, because you've got great skills. All of you have got great skills. But me, definitely, I'm not one to sit there and write a government proposal to push up to government. We would need help that. We've got so much in our heads that we would love to get out. I've always said that I could solve the problems of the world if some bastard would listen to me. But, it's about, where do you take all of the ideas and the solutions that there are to problems? Because every problem has a solution. It's just about thinking outside of the box sometimes.
Thank you. I think it's a good point. It's been said in a few of the talks already. We're probably sick of hearing about the problems. I think we all know those. It's about time to do something. Maybe I'll make an action for Andrew in the back to start writing a white paper or a submission or something that compiles a lot of these issues. Karen, I did have a question that's come through a few times online that I think basically relates to how do GPs or other providers know when someone's been vaccinated at a pharmacy? Is there any specific, obviously the answer there is probably the air, but I wonder if there's any specific communication or anything else like that that's generated.
There's not usually a direct message that would go to a person's usual care provider. All pharmacies have right access to the AIR, and it is mandatory, as everyone knows, from 2021 to document that on the AIR. So that's how other providers would be aware.
I have another question while we wait for more to come in, I guess, to all of the panel. We're a bit biased here. We always hear these great presentations from people that are passionate and doing wonderful things in this space. And, it's no question we've heard that today. But, obviously that's not universal across, whether it's healthcare sector, GP, pharmacy. There's a lot that aren't quite as passionate and informed and invested in this. How do we propagate that message to all of our colleagues? So it's not just the people at these meetings that are doing that, but it's people in all the other places we work. I might ask everyone to maybe comment on that.
Yeah, I think for the GP community, I think you need a lot of messaging, reinforcing, reminders, education sessions, and sort of just keeping it on their top of, their agenda. But yes, they have a lot to deal with, so sometimes it falls by the wayside. But you just have to keep at it and present it in a very time efficient, easy for them to digest manner.
I think I touched on this in my presentation, that organisations like the Pharmaceutical Society really need to step up and make sure that pharmacists are confident and do have that knowledge to make those recommendations. So it's just about educating our staff so that we do know that, educating the population so that they know that they can access vaccinations in pharmacy, and educating pharmacists so that we are confident to make those recommendations.
Most people want to do the right thing, so it's making clear what the right thing is and making it easier than doing the wrong thing. There's, in our case, in residential care, the Aged Care Quality and Safety Commission, setting standards. Hospitals, exactly the same thing. It's about creating expectations, which is what professionals sort of understand and know about, and then just making it or enabling it.
I believe every person's lives that I come across and touch, that they have the power to spread my message further. So if I'm in contact with 300 people, they spread it onto another 300 people, the message becomes a lot spread far and wide. So I educate and recruit my patients essentially to say, look, you know, when we draw up the vaccines, even talking to them, oh, this is a lyophilized vaccine. This is the reason it was created. Or you've received an enhanced vaccine. How come your husband didn't? And then they've gone on to question and chat to their colleagues and said, did you realize there's different vaccine technologies? So all of us, I think we do that and we continue to do so, but it's living, breathing, you know, walking the walk, talking the talk. And I encourage other people to do the same.
And in my role, we encourage, you know, people in
Is this
decision
working? Yeah, it
making.
is.
Yes. Hi, sorry, I just wanted to add to that. In my role, we really advocate for, you know, a seat at the table where immunisation issues are being discussed and decisions made, just so that we can have a say in how things are being planned and delivered. And we construct lots of messaging around, you know, getting immunised and through our social media platforms by having culturally appropriate and constructive messages. Again, just for the persistence, and we really encourage services that if a family comes in the door and there's a single mum with 5 kids, they're there for one health issues, offer and take that opportunity to vaccinate all people if you can, because the likelihood of them coming back and returning is not very high, because they've, you know, made that effort to get there in the first place. We've got to maximise and take those opportunistic opportunities.
Thank you. Having got a previous commitment from the PSA to provide background documents, I'd like to extend it to the PHNs that are involved here and the colleges. There's been a lot of complaints from various colleagues of mine about the new CME framework, you know, that you can't just come to one of these and tick 6 hours or whatever and accumulate that. Now you've got to actually think about what you're doing. You've got to do audits of stuff that you're doing. Last year, my audit was at the Swan Hill Aboriginal Medical Service. We looked at the number of people over 50 that had pneumococcal vaccine. The answer was 6%. And so we introduced a new service there whereby everybody that came in over that age had their vaccination status checked, and then automatically there was a note going into the clinician saying needs pneumococcal vaccine or something similar, because sometimes when you're busy seeing a patient's acute issue, you don't do anything about it. Now, what a wonderful opportunity for every GP to fix up their personal vaccination rates and pick up their difficult to get CME points at the same time. So if we could get the PHNs and the Immunisation Coalition and the college to put out something saying, here's how you do it. It's actually really quite easy. You've got computers that you can ask for the answer to these questions, and you can generate the lists, and you can also say opportunistically to your reception staff and your practice staff, this is something that needs to happen, and we're doing this because A, we get these difficult to get CME points, and B, all of our patients will be vaccinated after that. So if I can just get that in the minutes, that there's a commitment now from PHNs, the Immunisation Coalition and the College of General Practice to send the template out. It's in primary sense, is it? Oh, good stuff. Thank you.
Thanks. We had an online question for Anita. So do you think GPs would have discussions with their patients opportunistically around the protection effects of vaccination to help protect against age-driven diseases like dementia, Alzheimer's, etc., if sufficient evidence was provided to them, hence more buy-in from the patient?
I certainly think, yes, if there's more evidence, GPs will be very happy to talk about it, because I think at the end of the day, GPs just want their patients to be well and be out of hospital and have a good quality of life. And that means in addressing the risks of dementia or any other debilitating disease. So I think they would definitely, and it's just the time constraint that precludes those discussions sometimes. But I think we've got to try and seize the moment, do it opportunistically, or reschedule another appointment which they're coming in for another health matter, and use that to talk about this important issues. Yes.
Hi, this question is for Professor Murray. I presented at CIDC on a review of 1,000 aged care residents, almost 1,000, and their vaccination rates in our area. We've been doing a lot of work on coverage. It was very low. But this idea of consent has come up, and you've mentioned that already. And I don't entirely understand it, because I can't see that we're going through the same consenting process for perhaps an antibiotic or another medication in aged care as we are doing for an immunisation, which arguably is a much safer medication. Can you comment a little bit about that consent in aged care issue just a little bit more? Because I'm stumped at why it's different.
Are you hoping for a logical answer? Okay, because I was there at the time. I can tell you it's not going to be one. I'm not going to make you happy. Look, the problem is it's historical. And at the time when COVID vaccines first came out, there was a huge degree of paranoia. We set up a whole, working groups, looked over every perceived complication. We spent hours poring over clinical records to try and figure out whether this was true complication or not a complication. It's an absolute nightmare in aged care, because people have got, a list of problems longer than my arm. That's why they're there. We had OPAN on, strongly advocating in terms of people's rights to make sure that people like me who wanted a fast track, easy, simple, logical, perhaps logical is not a fair way to put it, perhaps a fast track way to have consent going forward was soundly squashed. And the view was that you couldn't consent for a risk that you couldn't adequately perceive. And there's some, logical truth to that. If you don't really know what the rate of complications were, there was data coming out of Northern Europe. People were a little bit worried and paranoid. And as it's turned out to be, it's largely been a non-issue. But at the time we didn't know. But the problem was that the rules and our attempts to change the rules made at that time basically squashed it. So we've now got, Michael Woodward sent me the consent form, and he said, what crazy person did this? It's longer than my leg. Not that I'm very tall. So I think it's possibly time to go back and have another look at it, because you're absolutely right. We've got people on all sorts of nasty drugs in residential care with much worse profiles, and we take it. We don't even worry about it. In fact, I dare say we don't even ask for consent. It's a bit of a nod and a wink to a blind, cognitively impaired person. So I'm absolutely on your side. It probably should be revisited, but we just lost the first round.
I think also just we seem to have expanded the consent issue into the other vaccines as well, because in our review, we found that even pneumococcal was requiring a consent now. And I had rates of 1.7 to less than 25% across 11 aged care facilities. So it's like the consent issue is actually not just expanded from COVID.
Worse than that, because you look at the psychotropics, anti-dementia drugs are listed as psychotropics. Oh my God. So the anti-dementia drugs I've got to actually justify in residential care. The problem is that we've gone a little bit overboard, and trying to figure out how to get back seems to be a bit of a challenge.
Thank you.
Preventive, not treatment. Otherwise,
So you're absolutely correct. Your comment was that the baseline is that they are a healthy person with no problems. So the first rule, do no harm, I guess going back to the ethics, is the risk for the vaccine, the potential benefits, they need to clearly outweigh the potential risks that the person might be facing. And it's different if somebody is receiving antibiotics because they are sick. The benefits are perceived to be much larger, and the tolerated side effects will be a lot, in my experience, a lot larger. There's a much bigger leeway given. So the baseline that you're starting for, the patient's expectations, risk benefit is what it comes down to. And it's a continually moving pendulum, I guess, year on year. The other challenge that struck me when I was working in aged care is these consent forms need to be signed every year. So that flu shot, it's not a one and done. Every year you have to go through the same painful process. Is that still the case in yours?
I think the army is more prepared for a nuclear biological warfare and a nuclear explosion, and they do more drills to prevent that from happening. And the amount of money the government spends in the military, and we were referred to, nurses and doctors and pharmacists were referred to as the military of the COVID era, the warriors. And yet there is not a single task force that we hear about in what we're going to do to prevent the pandemic. So, you know, that's, you know, we're working in silos. You know, your nursing homes are exposed, your rural and remote are exposed, yet there's not a task force out there. We're just feeding them to the enemies, a bit like letting the enemies come in different forms, like Saddam Hussein, Hitler, and Putin, attack rural and remote, leaving them exposed, but nobody's come up with a task force to say, what are we going to do? What exercise and drills do we need to do to prevent this from happening again? And we're still talking about consents and how GPs are working, how nurses are working, how we're working in silos. We should be a team. The artillery, the infantry, and the tank regiment should. I'm an ex-British Army nurse. I did better training to prevent nuclear biological warfare than I do as a nurse in preventing.
I think it's a really important point, and dare I say it, another potential role for a CDC when that's up and running and able to do that. So